Welcome, everyone. Thank you for joining us for our presentation titled Tumor Markers and Prostate Cancer Screening. It's my pleasure to introduce you to Dr. Victor Matei. Dr. Matei is a member of the HIFU Clinic medical team and currently works at the European Institute of Technology in Milan, Italy, as the head of urology training activity and the Institute's premier robotic surgeon. Dr. Matei has personally performed over 4,000 procedures, including over 2,000 endoscopic procedures and over 1,000 robotic procedures, utilizing the groundbreaking Da Vinci robotic system. He has been an adjunct professor at the Urological Residency School at the University of Milan's Faculty of Medicine for over 11 years. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. If any questions arise during the presentation, we encourage you to submit them in the Q&A box. Our speaker will address your questions following this presentation. Please join me in welcoming Dr. Victor Matei. I will now turn the presentation over to him.
Okay, good morning, everybody. I want to start my presentation with these two graphics that all you know, showing the effect of PSA introduction into the clinical practice on prostate cancer incidence and mortality and the rate of men presenting with metastatic disease. The reason is that based on this data, the expectation of significant positive results from a PSA-based screening were huge. The aim of any screening program, and thus of prostate cancer too, is the early detection of cases able to undergo radical treatment and having as final result the reduction of overall and cancer-specific mortality. As far as prostate cancer screening is concerned, the high rate of false negative biopsies and the high rate of clinical non-significant disease might decisively interfere and prevent to reach the expected mortality reduction as a final result of the screening program. Various reviews and meta-analyses of the European and the US screening trials showed that the benefit is really small and regards only the cancer-specific mortality, so to be weighted against the inherent risk of overdiagnosis and overtreatment. As the PSA is not a tumor marker but an organ marker, the early detection of potentially lethal cases is counteracted by a low specificity of PSA, while the risk of overtreat clinically non-significant disease is enhanced by the underuse of active surveillance. Based on the evidence of the risk of overdiagnosis and overtreatment and of the treatment important side effects, the US Preventive Service Task Force issued in 2012 a grade D recommendation against PSA-based screening, highlighting the limitations in the historical implementation of screening. The effects of this recommendation were a sharp decline of PSA tests, of biopsies, and the increase of patients presenting with metastatic disease, with the risk of reversal to the figures of the pre-PSA era. There was an increase of second testing before biopsy too, and an incentive to find more specific biomarkers. Moreover, it was an increasing understanding of the evidence that early detection has at least partially driven the observed prostate cancer mortality reduction over time. As a result, in 2017, the US Preventive Services Task Force upgraded the PSA screening to a grade C recommendation, meaning a balanced approach to prostate cancer early detection, emphasizing a shared decision-making and appropriate risk-based management for men at risk of prostate cancer concerning both screening and biopsy performance. If the testicular cancer is considered, the high efficiency of all therapeutic means underestimates the role of early detection, as overall cancer-specific survival correlates strong overall, and cancer-specific survival correlates strongly with the choice of the appropriate treatment, rather than with an early diagnosis. For the prostate cancer instead, the optimization of diagnosis impacts more decisively on the cancer-specific survival rather than the choice of an appropriate treatment. Biomarkers, both molecular and imagistic, may turn determinant in improving the efficiency of the diagnostic process, but also as risk stratification and thus in the therapeutic strategy. The use of biomarkers in screening and in the optimization of the diagnostic strategy is needed to avoid unnecessary biopsies and to improve the prostate biopsy performance in favor of clinically significant diseases. As far as the therapeutic aspect is concerned, the role of biomarkers might be relevant in risk-adjusted treatment choice. Moreover, novel biomarkers have been implemented to standardize an appropriate use of active surveillance. The diagnosis algorithm helps us to better design and develop biomarkers in order to improve the screening process, especially in some critical points. The share of the decision-making between the primary care provider, urologist, and patient is the cornerstone of the actual approach. The risk assessment and stratification aim to improve the efficiency of this tailored screening process. Risk factors impact both on the population to be screened and on the age when the start of screening. Surprisingly, looking for the review articles dealing with this item during the last 5 years, the conclusions are almost the same, despite relentless efforts. This paper written at the end of the 2015 warns about the need to increase the accuracy of PSA in screening to find more rapid and specific detection markers, suggesting as a possible solution the integration with genetic tests. After 5 years, this other review with the same item concludes identically, suggesting as imperative to overpass the deadlock the biomarker combination. As a consequence, the research must go on. In fact, looking into the body of these papers, some interesting data may be noted. As previously showed, due to its low specificity for clinical significant prostate cancer, PSA showed itself insufficient as a screening marker. At least if used alone. Prostate health index, 4 Kallikrein score, combining PSA isoforms, improved the area under the curve in the diagnostic setting. Gene and clinical data are also considered. The so-called novel serum markers, such as insulin-like growth factors, interleukin-6, and interleukin-6 soluble receptor, even if thought promising, they did not find practical application, and the last review does not even mention them. An interesting chapter is the urine markers. The PCA3 received the FDA approval to be used in patients suspicious for prostate cancer having a first negative biopsy. The genomic rearrangement, mostly gene fusion, involving TMPRSS2 and ERG transcription factor occurs in up to 50% of prostate cancer patients, having a specificity of 93% and a positive predictive value of 94%. Combines PCA3 with TMPRSS2 ERG to estimate the risk of prostate cancer and thus to help decision-making for prostate biopsy. The SELECT-MD test is designed to measure RNA levels of two genes, DLX1 and HOXC6. Exosomes are small extracellular vesicles involved in intracellular communication. Recent data has shown that first two mentioned by TMPRSS2 ERG can be detected in extracellular vesicle from urine samples, EXO-106, and integrated with clinical data, EXO-DX test. Prostasomes are secretory granules produced and delivered by prostate cells, allowing the spermatozoa survival in the female genital tract, and finally, the fecundation. Their ability of immunosuppression, invasive support, angiogenetic capacity are potentially cancer-promoting properties. And even if to assist fertilizing sperm cells after 50 years of age seem to turn against the host cell, promoting its malignant transformation. As a result, they potentially may become prostate cancer detection biomarkers. What about exosomes? They are also vesicles, smaller than prostasomes, containing microRNA, messenger RNA, and even viral peptides, content protected by a double membrane. The most important content are the microRNA, small non-coding single-stranded RNA involved in the regulation of mRNA. Their resistance to RNAs confirms them a sufficient stability in most body fluids. Here you can see microRNA involved in malignant transformation of prostate cells, while in this second table, microRNA involved in preventing it. Thus, microRNAs seems useful tools not so much for diagnosis than as predictors of clinical outcome of prostate cancer patients. An interesting chapter regards the tissue markers. The confirmed MD test performed on the tissue obtained from a negative biopsy analyzes the methylation of 3 biomarkers and may turn fundamental in indicating to repeat the biopsy. Here, the imagistic biomarkers. According to the 2 trials performing the multiparametric MRI before the biopsy, it reduces the overdetection of clinical non-significant disease by 37%, missing only 4%, and reducing the biopsy by 32%. As this pathway may be cost-effective only in the long term, actually it requires changes in healthcare system in order to accommodate appropriate MRI capacity and to guarantee the training needs for radiologists and neurologists. As a result, the use of molecular biomarkers might be useful in selecting patients and thus limiting the need of performing MRI, or in PRATS 3 already documented lesions, selecting patients who are to undergo biopsy. This suggested, even if crowded table, resumes the role and the utility of previously discussed biomarkers and their use in clinical practice. Even if all the mentioned markers outperform the PSA, they find limitation in a routine use. As a consequence, the development of gene panels combined with the imaging and clinical data may be the solution to implement their use. The most intriguing screening test seems to be this one, based on the circulating tumor cells using immunocytochemistry techniques. Here you can see the study design. In this non-randomized study, the positive predictive value and the negative predictive value resulted close to 100%, clearly superior to the PSA and even to the association PSA MRI. The combined circulating tumor cell detection and immunocytochemistry seems a very promising screening test waiting to be tested on a population level. And I conclude emphasizing that nowadays PSA screening has to be individualized, risk-adjusted, and associated with the MRI in order to avoid unnecessary biopsies. The circulating tumor cell identification using immunocytochemistry techniques seems the most promising screening test, but it needs further evaluation on population level. Finally, the integration with genomic tests such as microRNA may turn out imperative for both detection and prediction of clinical outcome. Thank you very much. And if there are some questions, I will be happy to answer them.
Thank you, Dr. Matei, for that outstanding presentation. We will now move on to the live Q&A portion of the presentation. As a reminder, please submit your questions via the Q&A box. Our first question is, why do you think PSA-based screening is not working?
So, mainly the problems are a low specificity for cancer significant cancer patients. So, with the PSA, there were discovered many patients having clinical non-significant disease. And that's why at the end of the screening process, the benefit of reducing the mortality was not evident because the majority of patients found with this disease were clinical non-significant, so they were fit only for active surveillance and not for treatment.
Okay. And our second question is, what do you think about circulating tumor cell detection?
So the circulating tumor cell detection is a very promising method. It was, of course, used before in discovering if the disease has or has not metastasis. Secondary, it was a very interesting study about the tumor circulating cells, showing that there were also stem cells and mature cells. The use of these circulating cells, tumor cells, is very promising because the technique used to find the tumor cells is the immunocytochemistry method that they are used also for example, in to see tumor cells in urine. And the technique is very easy and has a very good, very reliable. And that's why I think this is one of the best techniques to make diagnosis. In this study, there were also patients with second tumor or with 3 tumors, not only prostate cancer, but also kidney cancer or lymphomas. So this method seems really very promising.
Well, thank you again, Dr. Victor Matei, and thank you to the audience for those outstanding questions. We hope you found today's presentation to be informative and insightful. This presentation will be available for on-demand viewing. Don't miss out on the other valuable presentations on our agenda. Visit the Agenda tab in the auditorium for a full listing. Thank you again for your participation. Until next time, goodbye.